Hi, dear friends. I hope you have been doing well and enjoying your time. Welcome back to the Health Coding Hub. Let's get started on our journey towards better health and wellness. Today, we'll be discussing how to code the E&M document service. This is a huge topic, and we won't be able to cover everything in just one or two sessions. So this session is just an overview of the E&M documentary code. Our goal is to help you understand the logic behind the E&M coding so that you can become an expert. So today this you will need to do practice, but we will start with the basics of understanding the logic behind evolution and management. In this overview, we will talk about what the E&M service and the E&M categories, the code range for the categories, the place of service, and the type of patients and the E&M document structure, how to code the E&M, and finally we'll touch on 2023 updates of the E&M coding. So let's get started with the E&M service. As the E&M indicate, these medical codes apply to visits and services that involve evaluating and managing the patient health. Examples of E&M service include office visits, internal medicine, hospital visits, home service, and preventive medicine service. Medicare and Medicaid and other third-party payers accept E&M codes on claim that physicians and other qualified healthcare professionals submit to request the reimbursement for their professional service. E&M categories. E&M guidelines are written for the following categories: office visit or other outpatient visit, hospital inpatient and observation care services, consultations, emergency department services, nursing facilities services, home or residence services, prolonged service with or without direct patient contact on the date of evolution, and management service. Let's start with the place of service. The place of service and the service categories are defined by the location where the face-to-face encounter with the patient and family or caregiver occurs. For example, say service provided to nursing facility. Resident brought to the office is reported with office or outpatient place of service code. Let's say the example 01 place of service. This is for the pharmacy. Pharmacy, a facility or location where drugs and other medically related items and services are sold, dispensed, or otherwise provided directly to patient. The place of service 02 telehealth provided other than the patient home. So the location where the health service and the health related service are provided are received through telecommunication technology. Patient is not located in their home when receiving health service or health related service through telecommunication technology. Few more examples for the place of service. 11. This is for the office visit. The location other than the hospital is skilled nursing facility, military treatment facility, community health centers, state or local public health clinic, or intermediate care facilities where the healthcare professional routinely provided the examination, diagnosis, and treatment of illness or injury on an ambulatory basis. Place of service 20. This is for urgent care facility, location where the distinct from hospital emergency room and office or clinic whose purpose is to diagnose and treat illness or injury or for unscheduled ambulatory patients seeking immediate medical attention. Place of service 05. It is for the Indian healthcare service or freestanding service where a facility or location owned and operated by the Indian Healthcare Service which provides diagnostic and therapeutic surgical and non-surgical and rehabilitation services to American Indians and Alaska Natives who do not require hospitalizations. Let's start with the type of patient. So basically in E&M those are two types of patient, new and established. A new patient is a patient who has not received any professional service. Remember, it means face-to-face services within the past 3 years from the physician or qualified healthcare professional or providing the current E&M service or from another physician or qualified healthcare professional of the same specialty and subspecialty who is a part of the same group practice. And the established patient is a patient who has received professional face-to-face services within the past 3 years from the physician or qualified healthcare professional providing the E&M, or from another physician or qualified healthcare professional of the same specialty and the subspecialty who is a part of the same group practice. So below you can see the additional information. No distinction is made between new and established patient in the emergency department, because in the emergency department every patient is new to the facility. And the second information, physician who share the same tax IDs are the part of the same group even if they are different locations. Dear friends, let's discuss some common scenario for the new and established patient. So here first scenario is a physician leaves a practice to join a new one. A patient follows the physician to the new practice. So here for the established patient sees original physician at new practice. The patient is considered as an established patient for all physicians of the same specialty at the practice. But here in case of new patient, he sees to another physician in the new practice before seeing their original physician. For this physician, they are new patient. The second scenario here, the professional component of previous procedure is built within a 3 years time period. Example, lab interpretation is built and no E&M service or other face-to-face service is built. So in this scenario, the patient has not received any evolution management services, only he received the professional services like lab interpretation, and no E&M service has built. So there is no question about the established patient, but the patient who will be receiving first time any evolution management service here, then the second time he will be considered as established patient. But here the patient is not receiving any evolution management service, so the patient will be new to this practice. The third scenario, a physician and nurse practitioner are in the same office. The physician sees a patient, the NP later sees the patient. NP can perform and bill for new patient visit as long as the NP perform and document the service. The service meet the criteria for new patient visit. The NP bills under her own NPI, not the physician NPI. The fourth scenario here, a family physician sees a new patient and refer to a surgeon in the same group with the same tax ID. So if the surgeon has not seen the patient in the past 3 years, so she is considered as a new patient since physicians are of different specialties. The last scenario here, a patient present with a new problem within a 3 years for a visit. So for same specialty or for the same facility, definitely it will be established patient, because whether it is a new problem or established problem, but he visited to same physician, so it will be considered as a established patient. And for become a new patient, he need at least 3 years of time to be new patient. Let's discuss about the E&M code range. For the office or other outpatient services, we have the E&M code series 99202 to 99215. And for the hospital inpatient services, we have 99221 to 99239. And for the emergency department services, we have the series range 99281 to 99288. And for the critical care services, we have the code range 99291 to 99292. And for the nursing facility services, we have the code range 99304 to 99318. And for the preventive medicine services, we have the code range 99381 to 99429. Let's discuss the E&M document structure. which is essentially a subnode. This stands for subjective, objective, assessment, and plan. Under the subjective section, there are three subsections: history section, exam section, and MDM section. In the history section, there are four subsections: CC, Chief Complaint, HPI, History of Present Illness, Review of System, and Past Family Social History. Past family social history basically covers medical history, allergy, and surgical history, and family history. The exam section refers to physical examination, and the MDM section is for medical decision making. It includes three subsections: DMO, diagnosis and management options; data, test order or interpretation by the doctor; and the risk, the level of risk for the patient. Let's discuss the subjective chief complaint. A chief complaint is a concise statement that describes the symptoms, problems, conditions, diagnosis, or reason for the patient encounter. The chief complaint is usually stated in the patient's own words. For example, say the patient complains of an upset stomach, aching of joints, and fatigue. The medical record should clearly reflect the chief complaint. For example, here pain, shortness of breath, nausea. Let's talk about the history of present illness. History of present illness is a description of the development of patient present illness from the first sign or symptoms or from the previous encounter to the present. History having 8 elements like location, quality, severity, duration, timing, context, modifying factors, and associated signs and symptoms. Location, for example, say left leg; quality, like itching, burning, radiating pain; severity, the scale measurement like 1 to 10; duration, like started 3 days ago; timing, like comes or constants and goes; context, for example, say lifted large object at work; modifying factors like better when heat is applied; associated signs and symptoms like numbness in toes. Review of system is an inventory of body system obtained by asking a series of questions in order to identify signs and symptoms that the patient may be experiencing or has experienced. The review system consists the anatomical sites like constitutional symptoms, eyes, ear, nose, cardiovascular, respiratory, gastrointestinal, genitourinary, musculoskeletal system, integumentary skin system, neurological system, psychiatric, endocrine and hematological system, allergic and immunological system. Examples of review system: constitutional, the symptoms for the constitutional like fatigue, exercise, intolerance, fever, weakness, and impaired ability to carry out function of daily living; eyes, eye discharge, eyes itching, tearing or pain; ear, nose, throat, nosebleed, postnasal drip, sore throat, current or recurrent mouth lesions; allergic or immunologic like allergies to medication, foods, or other substance; cardiovascular, chest pain, tightness, numbness, palpitation, heart murmur, irregular pulse; respiratory system, cough, chest pain, or deep inhalation; gastrointestinal, indigestion, pain associated with eating, burning sensation in the esophagus; genitourinary, include painful urination, urinary patterns, hesitance, flank pain; musculoskeletal, like joint swelling, redness or pain, joint deformities; integumentary, sore, lesions, nail color or texture; neurological dizziness, fainting or unconsciousness, psychiatry, depression, exercise, excessive worrying or stress, endocrine like sugar reading at home, sudden changes in height and the weight, hemological lymphatic, swelling in the glands, night sweats. Let's talk about the past family social history. Past family social history consists of review of three areas: past history, including experience with the illness or operations, injuries, and treatments. Family history, including a review of medical events, disease, and hereditary condition that may place the patient at risk. Social history, including an age appropriate review of past and current activities. Here we can see the example for the past family social history. Procedural surgical history, cherry type malformation, decompression, allergies, latex, social history, tobacco half pack per day since 20 years, denies ethos, denies drug use, family history, diabetes, per patient grandmother decrease at 38 years of age from blood clot, father and sister both with the diabetes. Documentation requirement for the physical examination will include the constitutional eyes, ear, nose, mouth, cardiovascular system, respiratory system, gastrointestinal system, genitourinary system, musculoskeletal system, skin, neurological system, psychiatric system, hematological system. Here we can see the example for the physical examination like general 9 IBS, weight loss, chest, symmetric lungs, heart, no murmurs, abdomen soft, GU deferred back normal, neuro left sided hemiparesis, extremities limited range of motions of knees, skin no rashes or lesions noted, endocrine intact. Since January 1st, 2023, the history and physical examination requirements have been eliminated. Only documentation purpose we are learning here, and coding guidelines will change the code selection requirement to be based on only medical decision making or total time of the EM service. The revision eliminated the requirement to meet a certain level of history and exam, instead requiring a medically appropriate history and physical examination. The goals for these changes were to reduce administrative burden and better align coding with how patient care is delivered today. Patient care should be driven by the needs to treat patient, not the need to satisfy coding requirements. Let's talk about the medical decision making. Those are four types of medical decision making are recognized. Level 1 straightforward, level 2 low complexity, level 3 moderate complexity, level 4 high complexity. The concept of MDM level does not apply to 99211 and 99281. MDM includes establishing diagnosis, assessing the status of condition, and or selecting a management option. MDM is defined by three elements. These are the number and complexity of problems that are addressed during the encounter. And the second one is the amount and complexity of data to be reviewed and analyzed. These data include medical records, tests, and other information that must be obtained, ordered, reviewed, and analyzed for the encounter. These include information obtained from multiple sources or interprofessional communication that are not reported separately, and interpretation of that test are not reported separately. Ordering a test include in the category of test encounter. Ordering a test may include those considered but not selected after shared decision making. For example, a patient may request diagnostic imaging that is not necessary for their condition, and discussion of the lack of benefit may be required. Alternatively, a test may be normally be performed, but due to the risk for a specific patient, it is not ordered. These considerations must be documented. Test document, orders or independent history. Each unique test order or document is continued to meet the threshold number. Independent interpretation of test not reported separately. Discussion of management or test interpretation with external physician or other qualified healthcare professional or appropriate source not reported separately. The third element of MDM is the risk of complication and morbidity or mortality of patient management. This includes decisions made at the encounter associated with the diagnostic procedures and treatments. This includes the possible management options selected and those considered but not selected. After shared decision making with the patient and or family, let's say example may include a psychiatric patient with a sufficient degree of support in the outpatient setting or the decision to not hospitalization a patient with advanced dementia with an acute condition that would generally warrant inpatient care, but for whom the goal is palliative treatment. Shared decision making involves splitting patient and family preference, patient or family education, and explaining risk and benefit of management options. Let's discuss the MDM table. If you are having a trouble seeing it, don't worry. I will share a link to the document in the video description. The level of medical decision making table is guide to assist in selecting the level of MDM for reporting an EM service code. The table includes the four levels of MDM, that is straightforward, low, moderate, and the three elements of MDM, that is number, complexity of the problem, address at the encounter, and the amount complexity of data reviewed, analyzed, and the risk of complications and morbidity or mortality of patient management. To qualify for particular level of MDM, two of three elements for the level of MDM must be met or exceeded. Example in the table may be more or less applicable to a specific setting of care. For example, say the decision to hospitalize applies to the outpatient or nursing facility encounters, whereas the decision to escalate the hospital of care or example transfer to ICU applies to the hospitalized or observation of care. In our next session, we will discuss more about the MDM table, time-based coding and some medical scenario. Thank you so much for watching the video.